Ladies and gentlemen of the World AI Show, it is time for our government keynote on outlining the government strategy for health, and we're later to be joined by Sutowo Wong, the Director Data Analytics, Ministry of Health, Singapore. Well, Sutowo is responsible for analytics strategy, management, and prioritization of analyticals, profile, capability development, data management, and data science in MOH. He worked with organizations in public service, healthcare, pharmaceuticals, CPG, retail, telco, banking, insurance, energy, airlines, and hospitality in Southeast Asia, China, India, and Japan. Well, with this, I'd like to humbly invite on the stage and screen Sutowo Wong to join us. Sutowo, thank you for joining us and being a part of our wonderful event. How are you doing today? Hope you're doing well.
I'm doing very well, thanks. Thanks for the introduction.
Likewise, so over to you. Thank you.
Thanks. Share my screen.
Sure, Sutowo.
Are you able to see my screen?
Yes, we just request you in the presentation mode. The screen.
Yep.
Yeah, perfect. Over to you.
Thank you. Okay, so today I'll be sharing a bit more about our health AI strategy in Singapore. I have actually structured the sharing around 5 different areas, starting with sharing a bit more about our operating context, and then diving into the components of our AI strategy, and then explaining a bit more about how we are building the enablers to achieve the strategy or to support the strategy, and also then going into some use cases to see how the strategy is being applied, and then looking ahead, what are some of the other things that we are looking forward to. First, before we look at our AI strategy, we need to be cognizant of a lot of things that are happening in the broader market. There are 3 things that we are seeing in the market right now. One is the democratization of data, which means more and more people want to have access to data. And we need to think about how do we then democratize the data? How do we deliver data and insights to them? The second trend that we see is the rise of analytics apps. These are role-based, relevant insights that are delivered to the people who are doing specific jobs. Take, for example, the people who are doing health claims adjudication will want to know whether a claim is potentially non-compliant or even outright fraudulent. But for someone looking at operations in a hospital, for example, looking at capacity management, will want to know what is the bed occupancy rate, want to know how many patients are waiting for beds and how long have they been waiting. So it has to be relevant to the role. And finally, it has to be actionable. People have to be able to take actions, make decisions based on the insights. So these are the 3 macro trends that we see out there in the market. And these also help us shape our data strategy. First, as more and more people are using data, of course, then we have to look at the user experience, and it matters a lot. Because if they are not having a good experience, they will not be able to exploit the data and use it for AI, for example. And what we have done is to do a journey mapping across the different stages of the data lifecycle, engaging about 200 stakeholders we have across the public healthcare. And we actually put our insights according to the different stages of the data lifecycle. I won't go through everything here because there's quite a lot to go through. I'll just touch on a few of them. Take, for example, at the acquisition stage where we acquire the data, there's usually significant lead time and cost. The way it works is that when someone comes up with a use case, typically what happens is that this person will have to identify the data needed to support the use case. Then the person will have to make a request for the data to be extracted into their local machine. And that process itself takes sometimes even months. And by the time the data arrives, the use case could have shifted, the business needs could have changed. Another area is around management, where there is a lack of comprehensive data catalog, and even data standards that are being used could differ across the different institutions. From an access and distribution perspective, there is also that fear of residual liabilities. Right? We do a lot of data sharing across different institutions because we want to have a national view of the patients. And therefore, there's a lot of data sharing that's being done. And the data provider naturally is worried that what will be the residual liability if I share the data with another entity who is now the data controller? What happens when there's a data breach? And this is a very real concern that we actually have to address. And finally, on the exploitation end, a lot of people are doing analysis on their end devices, using their laptops, for example. They are asking for better and better laptops, which is not tenable. And also with data scattered across many endpoints, it's also becoming a nightmare when it comes to data governance. The lesson number 2 really is around, just now I mentioned, right, the two trends, relevance of insights and also actionability of insights. The question is to who? Obviously, the Ministry of Health is not the center of the universe. If you're doing public healthcare, we need to think about who else are our stakeholders and how do we then get relevant and actionable insights to them. If you look at this, on the left-hand side, what we call the government entities who are in the Ministry of Health family. So apart from the ministry, we have our Health Science Authority, or we have Health Promotion Board and the different professional boards, for example, Singapore Medical Council. On the right-hand side, the non-government entities, right? They are governed by a different rule. On the government side, we have our data management rules for the government. On the right-hand side, these are the non-government entities that are governed by Personal Data Protection Act in Singapore. If you see, we have 3 different healthcare clusters, National Healthcare Group, SingHealth, and NUHS, National University Hospital Systems. They are supported by our health tech agency, IHIS, and also AIC, Agency for Integrated Care, that does all the ground engagement and operations for a lot of our health programs. So overwhelmingly, we have people or entities actually on the right-hand side, which are governed by a different rule from the people on the left-hand side. Next, I'll dive a little bit into our data AI strategy. Our AI strategy for health is actually aligned with our national AI strategy. We launched that in 2019, where the vision is for Singapore to become a leader in developing and deploying scalable, impactful AI solutions in 5 key sectors, healthcare being one of them. So it is aligned to the national strategy, and I'll dive a little bit into what we do in health. We use a 2-pronged strategy, focusing on both the use case and the ecosystem enablers. So what we want to do is to transform and enhance policy decision-making, delivery of care, influencing or impacting positively the patient outcome. But we are also cognizant that AI can be applied very often to internal operations as well. And we don't forget that. So we are not just looking at front-end patient-facing application of AI, but also internal operations. So that then we can focus on the development and the deployment of the scalable AI solutions. The key word here is scaling. We want to be able to scale because we have done a lot of pilots in AI. The key priority for now is to look at how then we can help the pilot scale at the national level. So that is divided into 3 different work streams where we are looking at developing this vision, strategy, and framework for health, which is already completed. The next 2 work streams really is around identifying the use cases that are impactful. Not at the moment, there are a lot of R&D use cases, but our focus for our health strategy for AI really is to look at those that has already demonstrated clinical effectiveness and also operational feasibility. Looking at those use cases, and then we can look at them, what are the impediments to scaling? And how do we build the enablers to help them scale, be it in the area of IT infrastructure, governance, and also funding. I'll dive a bit more into the enablers themselves, some of the things that we look at to help us actually scale many of the AI use cases. I spoke about governance earlier, right? This is the what we call a term as agile. That's the way to pronounce it. The Artificial Intelligence in Healthcare Guideline that's been published by MOH. We co-developed that with Health Sciences Authority and IHIS, our health tech agency. The whole idea is that we are looking at how to complement HSA's regulation around AI for medical devices. For this area really is focusing more on HSA's regulation focus on commercial AI products. But we do notice or realize that there is a gap when it comes to AI solutions that are developed in-house. So this guideline is meant to do that. And the guideline has 2 parts, recommendations for the developers of AI models for AI solutions, and also the implementers of the AI solution. So we will be touching not just the AI developers, but we're also touching the clinicians, the administrators who are actually implementing the AI solutions. The other area is around data governance rules. Right? I actually alluded to that earlier, where I spoke about having two different types of entities. We have government entities who are governed by one set of rules. We have non-government entities that are governed by Personal Data Protection Act or PDPA in Singapore. So in the data sharing, then we have to be very clear about what are the roles played by each party. What are then the obligations? For example, IHIS in this case act as a data intermediary for the data sharing between the public healthcare institutions and, say, the Ministry of Health. And only when we have clarified the roles and the obligations, that's where people have the comfort that if something bad happens, like, for example, a data breach, what will be the liability for each one of us? But I think that's the prerequisite for us to be able to share data freely and in a secure manner. The next enabler is around IT infrastructure. On the top right-hand corner, we have MCDR, which is the MOH Consolidated Data Repository, which is meant a data platform for government users. That's where we centralize a lot of the data collection or acquisition and central data management, for example, cleansing of the data, standardization and harmonization of the coding and the definitions used. And for the use cases that are required by our users in public healthcare institutions, we will then push the data over to this platform called Brain, which is a data platform that is built to support our PHI users, or public healthcare institution users. On the left-hand side are how we share data with research and industry. We have a platform called Trust that's built on government commercial cloud. It is a cloud-based platform that allows us to share data more efficiently with our non-government entity users. Apart from having the governance and making clear the governance rules, having the platform is not enough. We need to be able to upskill our workforce to be able to take advantage of the data. And we do have a whole of government competency framework, which allow people to look at improving their competency in data, all the way from basic to intermediate to advanced and expert. And along with it, there's a training roadmap where there are specific training courses that has been curated centrally. And then we allow access to the users for them to see what are the training courses that are relevant for their competency that they are interested in building. And then that has even been integrated into the HR management system. Next, I'm going to go into a bit more on how we apply our AI strategy in the context of use cases. A lot of focus that we have right now is around AI and genomics, and I'll go through a few examples in that. On the left-hand side here is the application of AI, more specifically in the area of natural language processing, where we then look at analysis of free text clinical notes to identify clinical symptoms for example, acute respiratory infections, which is actually very useful for us in the context of COVID. On the right-hand side is the application of what we call phylogenetics. It studies the genetic relatedness of COVID virus subtypes. And when that is applied with the traditional epidemiological investigation, it's very powerful in identifying the source of infection. And that helps us identify and rationalize the different COVID-19 clusters or infection clusters, and so that future public health actions can be taken more effectively. Apart from infectious diseases, of course, we look at chronic diseases, diabetes, hypertension, and hyperlipidemia being the important ones because they are the major causes of cardiovascular diseases, which actually occupy a big portion of our burden of diseases in Singapore. In fact, you may have heard about this. Singapore has declared war on diabetes a few years ago. Because it's actually one of the key chronic diseases that's causing a lot of downstream impact from a health perspective, from a cost perspective. In response to the war on diabetes, we have actually developed this thing called Selena Plus. It stands for Singapore Eye Lesion Analyzer. It is an AI-based screening tool for diabetic retinopathy, which is one of the leading causes of blindness for working adults worldwide. It has managed to attain an accuracy level of more than 90%, and it's been deployed to all 20 polyclinics. Polyclinics are actually subsidized public primary care facilities in Singapore, and it's actually benefited about 120,000 patients annually. And we are hoping to see how we can further expand this to be able to detect other forms of diseases. Next is AI in Health Grand Challenge, where the challenge is to look at how we can stop or even slow or even stop progression of diabetes, hypertension, and hyperlipidemia by 20% in 5 years. So there are a few research teams whom we have selected for funding. The ones that has been actually moved to the next stage really is to look at how they can apply, for example, AI in doing screening, and also looking at how they can provide decision support, clinical decision support in primary care and specialist care. And last but not least, also looking at behavioral nudging for patients and caregivers. So after going through the use cases, I'll just touch on very briefly on what we are looking ahead. In terms of AI, we have done a lot of work, but it's not just AI, because the entire digital health innovations actually presents a lot of opportunity for us to redefine our care financing model. We are moving a lot into what we call population health, a lot of work around how we bring healthcare upstream or into health promotion, into health prevention, preventative care into the community. So that's where a lot of this digital health innovations and solutions will be very helpful in redefining the way we deliver care to our patients, and also looking at how then we can look at bending the cost curve, because our healthcare cost has been rising quite rapidly. We are looking at then ways and innovations to help us bend or reduce the growth trajectory of our costs. So I'll end here. Thank you very much for giving me the opportunity to share our AI strategy in Singapore for health. Thank you.
Thank you so much, Sutowo, for joining us and giving us your valuable time and being the government keynote at the World AI Show Singapore. Thank you once again, Sutowo.